Dr. Neal, you're the anchor man, closing us out.
Good afternoon, everyone. Thanks for sticking with us to the very end. I'll try to make this quick because I know everybody's been starting to get kind of a long day. This patient was a 74-year-old female that presented with some symptoms of exertional lightheadedness over the past few months. Noted that she was previously doing pretty well, but with normal exertion, she had started getting lightheaded, started having to stop due to fear she felt like she might pass out, had to sit down. Kind of a typical story for this type of patient. History of diabetes, pretty poorly controlled, CKD3, no prior surgical history, former smoker, no relevant family history. So she was found to have a murmur on exam, underwent TTE, and was found to have a very high mean gradient with a small valve area, and just to pile on a little bit of mild to moderate MS. So she underwent a CT, annulus perimeter that fit with a 26, adequate coronary heights, sinuses a little bit on the small side with pretty significant calcification, as you would expect in someone with that kind of gradient. Good femorals for a transfemoral TAVR. And on review of her history, found to be intermediate risk, and elected both at her wishes and after discussion with the valve team to undergo transfemoral TAVR. So everything up to this point kind of standard, femoral access, went up with the pigtail, deployed the valve to 80% and checked just to check our position. Looks pretty good. You'll note that depth probably 3 or 4. And then the valve was deployed, looked pretty good on the pre-shots, and you'll notice that clearly the valve is not where it was in the last shot. For those of you that don't do a lot of TAVR, obviously this is kind of at -1, -2, almost sitting in the sinuses at this point. But you'll note not a lot of PVL. You can see the leaflets up here. You still see the coronaries at this point. So
John, I'm not sure that's -1, -2.
what would you say?
I would say I don't know. It's too short in this view.
Loop it again. Oh, I was asking him to play it again.
Let me ask you a question, John. What if it is -1 and it's not leaking? Are you gonna worry about that? That's a yes or no?
No.
Why not?
I mean, you still have some sitting in the leaflet, the calcification of the leaflets. It still looks like it's anchored pretty well.
People worry about when it's high. People worry about the valve shooting out and the aorta going down to the toes.
No, more about the, I think, coronaries.
It goes to the ventral.
Yeah.
So if you're stable at 5 minutes, you'll be stable at 5 months.
Right.
That's not the issue.
But we'll loop this, though.
The issue I'm worried about is you said your sinuses are 25, which is below the IFU for a 26 valve, and you have a high implant now.
But she's got high coronaries, too. But you still can't determine the depth in a single view, particularly the LAO view. You really need to come over to the RAO view because that stretches out the LVOT. We don't do it all the time. We really should.
Yes, sir. Well, that was done, and I didn't include that here, but it was felt to be adequate. I think everybody was comfortable with it. The device delivery system was pulled back. The proglides were deployed. TTE looked good. No significant leak. Obviously, we still saw the coronaries here. But while the proglides were being deployed, the patient developed kind of diffuse ST elevation on telemetry. And TE showed global hypokinesis, and ultimately the patient arrested, requiring CPR. The 6 French contralateral sheath luckily was still in place, so it was quickly upgraded to an 8 French sheath, and an in-snare catheter was advanced due to presumed coronary obstruction given the slightly high implant and the ST elevation. And we didn't actually capture the snaring, but here you can see the valve is obviously snared back, and the patient quickly recovered hemodynamically at that point, and the heart basically went back to normal, a little bit hyperdynamic state after a little bit of epi. So at this point, I guess what would be y'all's next step? Probably we implant another valve, I guess.
What valve?
Another.
I was going to say you could switch to an S3.
I must not have been here, guys. I don't know what you do. You're below the IFU for a 26 valve. The IFU for 26 valve is 27. And the problem with self-expanding valves is you often don't include right away, you include at some point later. But if you put in an S3, if you're going to include it, you include it right then and there. So an underfilled 23 S3 is a lot safer option for you. Yeah, the less. The less. I mean, the vast majority of S3s
You say less, but it's underreported.
but I mean, those are usually months later. Whereas the self-expanding, when you blow the IFU, it creates low flow areas. That's often the first 48 hours. Now, this was quick enough. Fortunately, this didn't happen an hour later. Because you probably
Right.
it happened while you were still there.
Yeah, luckily as we mentioned, the 6 French teeth had not been pulled out, so you're able to, you already have access essentially to kind of rescue yourself. So here, if they went back in with another 26 millimeter core valve, probably a little bit deeper implant this time just to make sure.
Why you play deeper? What's your thought process?
Something caused it to kind of slip the first time.
What causes it to move?
What caused it to occlude? Probably riding a little bit too high.
12 millimeters at a solid skirt. And so even if your corners are above that skirt, -1, you're going to cover the first 13 millimeters, just completely covered.
Right,
As opposed to once you get to the valve, they have open sinuses.
right.
So yeah, if I was going to put it in again, I'd have to lower it.
Now we see the fully deployed valve, this time with a little bit better coronary flow, obviously a little bit lower, and stayed kind of where it was initially deployed this time. Here you can see the snare still attached to the other valve.
Mr. John, go back to the first valve release.
Okay.
Yeah. It shows the angio. Yeah, well, when you can see a pretty good sized left sinus of Valsalva, it looks like it clears a little slowly.
Flow's a little slow. Yeah.
You can see how things go right from the side to reduction. The side to reduction is really small. It's only the bottom of the valves, the skirt, is small enough to make it the best you can. And this particular case, being high, made you pay a penalty. I mean, going lower. Now, the question I would have, Colin, is, Neal, once you did the second one, it looked pretty good. Did you think about selectively canning on the corners just to be sure? Or just say, thank God we're okay.
Yeah, I think we selectively engaged after the snare, but once the second one in, yeah, it looked good and she was doing well. I mean, we watched her a little longer, after the protamine went in.
Yeah, I didn't include it, but there's a selective shot of the left and right for just to make sure, first of all, nothing embolized downstream, and secondly, to get a better idea of the height.
I think that the snaring it going back is brilliant. What happens, a lot of people try to get it engaged and spend 15 minutes doing that, and then it's too late, as opposed to just doing something to reopen flow.
Right.
And once you pull this thing back, the whole valve falls into place, and it's basically like this had a BAV, and now you can let them recover it and rethink that.
Right, and most patients tolerate a little bit of AI while you're re-implanting a valve. I mean, just like we do a BAV.
Well, once you pull that valve back, unless you rip the valve, you're usually just going back to the valve they had before.
Right.
The BAV,
Right.
Use it a little bit better.
So her clinical course, she was monitored in the ICU overnight. By the following morning, she was awake, responsive, and pretty much no neurologic sequelae as far as we could tell. The post-procedural echo, other than the extra valve in place, looked pretty good. Mean gradient was 12, DVI 0.57, no significant PVL noted. And she was able to be discharged to rehab on post-op day 8 for a brief stay. At follow-up was doing very well at 1 month. So talk a little about some of the risk factors for coronary obstruction. Female sex, presumably due to, as Dr. Reardon mentioned, smaller sinuses, typically a little bit lower coronary height on average, and coronary height of less than 10, sinus width of less than 28, as you mentioned. And it's actually a little bit more common with balloon expandable valves in general, though obviously can be seen with self-expanding valves. And then, as you can imagine, the degree of calcification, those big chunks of calcium can occasionally land right in the coronary after implantation. The most common presentations, unexplained hypotension, obviously in this case ST changes, or just ventricular arrhythmias that occur immediately after implantation. There is some, obviously, literature, or growing literature, as Dr. Kleiman mentioned, about delayed coronary obstruction, and it's probably underappreciated in general, just due to the fact that there's a lot of reasons that someone can die 2 months later, especially someone that's high risk or at this stage intermediate risk, that could potentially be other explanations, and you wouldn't necessarily think of this right away. Management, stenting is successful in the majority of cases, though given the strength of the valves, occasionally it requires a second stent to increase the radial force of the stenting in up to 13% of cases. Emergent bypass is a second option, obviously much more invasive in patients that weren't typically good surgical candidates to begin with, historically. Although snaring of the valve is an increasingly recognized and used option, especially when the coronaries are not accessible immediately after the procedures. Dr. Kleiman mentioned sometimes you try to get in and can't do it. If you spend a lot of time doing that, the patient gets further down the shocks.
If you spent a lot of time doing it, you don't have any options left.
Right. You don't
Remember, not all valves can be snared. You can't snare an S3.
Right.
So if it's a core valve, you pull it out. If it's an S3, you try to get into the coronary. It usually works because, when it's an the mechanisms are different. The core valve creates a tube graft, and you often can't get through the tube. The S3 will push a calcified cusp up against the edge of the sinus and occlude the orifice that way.
Right.
Joe, what's the problem with going on bypass for this case versus the case that you showed earlier with their whole aorta?
For one, you don't have a large bore arterial access immediately available because you've already closed. Say what?
You still have it. It's easy to go on bypass. What are you missing if this person goes on bypass?
You don't have a way to get good cardiopreservation, I would imagine.
There's no point of it.
Right.
You're ischemic, whereas the other guy wasn't ischemic. You're protecting the organ. So even if you know bypass and support him, you still got to move pretty quickly there.
Right.
If you do get opened up successfully, what's the mortality?
I would imagine pretty high, but
50%.
yeah.
50%. I mean, if the saving bit like this takes a really quick action, but the people that have coronary occlusion and it's successful, mortality 50%.
Yeah.
So if you go on bypass, why not just open the aortic root and pull the valve out first?
What if you want to open the chest?
Yeah.
I mean, so if I did that, then I put retrograde. Clamp and start running retrograde trying to plead you while you're opening up, pull the valve out. There's one thing I can do if you open the chest. And we're all trying to do things that don't require us to open the chest.
Of course.
Now, what would have been one of the problems if I take this lady to surgery? Her hand is a little tiny bitty.
Right.
I mean, this is a tiny. I mean that works out to like 21.3 perimeter throughout diameter, which the best you're going to get in a surgical valve, you have to squeeze a 19
right.
or do a big fusion large cut or lower leg.
Yeah.
She was also 350.
Good. All right. That's a wrap. Thank you all for your time and attention, and thank you to speakers for really excellent talks.